Hi guys, welcome back to another video. We're going to continue our discussion about antihypertensive medications. So I hope you've seen the first two videos. So this is part 3 of these antihypertensive med series. Okay, so if you've been following this series, the first part was about diuretics, and then the last video we talked about sympatholytics, so our alpha and beta blockers, and today we're going to discuss vasodilators. So vasodilators can work in 3 different mechanisms. So the first one, they can block calcium channels. So these agents are called calcium channel blockers. And in this, we have 3 subtypes. We have phenylalkylamines, we have benzodiazepines, and dihydropyridines. The second way in which vasodilators may work is via the release of nitric oxide. And nitric oxide is a very potent vasodilator. And the third mechanism as to how vasodilators can work is via the opening of potassium channels, leading to hyperpolarization and therefore vasodilation of the vessels. Okay, so firstly, let's discuss calcium channel blockers. So calcium channels are found in all sorts of different places, but for this discussion, we're going to focus on the calcium channels found in our myocardium and the smooth muscles of our vessels. So the way that these calcium channel blockers work is they decrease the entry of calcium into the vessels and into our myocardium. So in a normal physiological setting, the influx of calcium leads to the contraction of our myocardium and the constriction of the vessel wall, leading to an increase in blood pressure. But if we give calcium channel blockers, which block these channels and therefore block the influx of calcium into the vessels and into the myocardium, we get vasodilation in the vessels, okay? And that's because we don't vasoconstrict, we vasodilate, we relax those arteries and arterioles. So this primarily works on the smooth muscle of the coronary arteries as well as the peripheral arterioles. They do not have any effect on our veins, okay? So the way that they work in the heart is they reduce cardiac contractility, which is the force of contraction, and decrease the AV conduction. So that means if we slow down the atrioventricular conduction, then we decrease the heart rate. So those are the net effects of calcium channel blockers. There are 3 different classes. So as I mentioned in the previous slide, we have phenylalkylamines, benzodiazepines, and dihydropyridines. So firstly, let's discuss phenylalkylamines. So an example of phenylalkylamine is verapamil. So verapamil, it is the least selective of all of the 3 different classes of calcium channel blockers. So phenylalkylamines are the least selective, and that just means that they have significant effects on both the cardiac tissue and the smooth muscle. So they affect both the heart itself and the vessels, okay? So it also has the max cardiac depressive action. So it has like the greatest effect, the greatest cardiac depressive effect out of the 3 different classes, okay? It is indicated for the treatment of hypertension, as well as angina, paroxysmal supraventricular tachyarrhythmias, as well as atrial fibrillation, okay? It's also used for the prevention of migraine and cluster headaches. So it's contraindicated in patients with heart failure, because in heart failure, the patients, they already have low cardiac contractility, and therefore giving calcium channel blockers, giving them phenylalkylamines will further promote cardiac depression, because these agents are already negative inotropes, which mean that they already weaken the heart's contraction and slow the heart rate. So if we give patients with heart failure these drugs, we're just gonna make the problem even worse. We're just gonna encourage more cardiac depression. So the second class of calcium channel blockers are the benzodiazepines. An example include diltiazem. So diltiazem, it affects both the myocardium and the smooth muscles of the vessels. However, it has less negative inotropic effect compared to verapamil. So it doesn't weaken the heart as much as verapamil does, but it's still a negative inotrope, which is why it's contraindicated for heart failure, for the same reason as I mentioned in the previous slide. You know, in heart failure, the heart is really weak, and therefore giving more negative inotropes would just further encourage cardiac depression. The third class of calcium channel blockers are dihydropyridines. Examples include nifedipine, which is the prototype, felodipine, nicodipine, and amlodipine. So these drugs, they have minimal direct cardiac activity, and they mainly act on the smooth muscle vessels because they have a greater affinity for the vascular calcium channels compared to that of the myocardium. So they act more on the smooth muscle walls compared to the myocardium. And again, they have less negative inotropic effect compared to verapamil. So they don't weaken the contractions as much as verapamil does, okay? These are safe for pregnancy, and they have very little interaction with warfarin and digoxin. Okay, so calcium channel blockers are suitable for hypertension. It's okay for the chronic use and at any stage of the hypertension, okay? So they're also safe for asthmatics with hypertension and patients with diabetes mellitus who need some drugs for their hypertension. Calcium channel blockers can also be used as an initial treatment or as an additive treatment for hypertension, so you can add that to other drugs, for example. We can also give CCBs to patients with peripheral vascular disease, and this is because, you know, as we've mentioned, they promote vasodilation, and therefore if we give them to patients with peripheral vascular disease, then we can increase perfusion to the extremities and therefore help with this condition. All calcium channel blockers are also used in angina, okay? The cons include their short half-life, so it's only 3 to 8 hours, and they cause reflex tachycardia as a compensatory mechanism to combat the decrease in blood pressure caused by the vasodilation. Adverse effects include, so verapamil may precipitate a first-degree AV block, so first-degree AV block, okay? Generally, CCBs can cause dizziness and headaches, as well as peripheral edema due to the vasodilatory effects that they have. Dihydropyridines, especially nifedipine, may cause gingival hyperplasia. And nifedipine was used sublingually for hypertensive emergencies, but now that's banned due to the high risk of reflex tachycardia, as well as angina and ischemic heart disease. Contraindications, so verapamil and diltiazem are contraindicated for patients with AV block and heart failure, as we've already discussed, because they are negative inotropes and you don't want to give that to patients with already weakened heart, as in, for example, in heart failure. So the second way that vasodilators work is they can act through nitric oxide. So we have two drugs here. Let's start with hydralazine. So hydralazine is a vasodilator, and it works by preventing the oxidation of nitric oxide. So nitric oxide is a very potent vasodilator. So if we prevent the oxidation of this chemical, then there's more of it circulating around, and therefore we get more vasodilatory action. So effects include arteriolar vasodilation. This doesn't have any effects on the veins. So if we dilate our arterioles, then we reduce the total peripheral resistance. And if we reduce our total peripheral resistance, and then that means we decrease our blood pressure. Okay, so that's how hydralazine works. Hydralazine is safe in pregnancy, and it's used to manage moderate to severe hypertension. Adverse effects include reflex tachycardia, as well as the increase in renin to compensate for the decrease in blood pressure. Those are just the compensatory mechanisms. It may also precipitate lupus-like syndrome, which is reversible. I think upon stopping the medication, you get the symptoms to go away. And at high doses, they can actually be toxic. Okay. The second drug that vasodilate our vessels through the action of nitric oxide is Nitroprusside. I actually don't know how to read this. I think it's Nitroprusside. I might be wrong. But the mechanism of action is they promote the release of nitric oxide. So as I said, nitric oxide is a potent vasodilator. So if we have nitric oxide circulating, then we basically promote vasodilation. And vasodilation reduces total peripheral resistance and therefore reduce the blood pressure. Okay, so in contrast with hydralazine, nitroprusside, they have an effect on the arterioles and the veins. Okay, so they promote arteriolar and venous dilation. They are indicated for hypertensive emergencies given as IV infusion. And cyanide toxicity is one of the adverse effects if given at high doses. Okay, so the third and final way that vasodilators can work is by facilitating the opening of potassium channels and therefore leading to hyperpolarization and therefore vasodilation. So here we have two drugs again. We have minoxidil and we have Diazoxide. Let's discuss minoxidil first. So minoxidil, the way it works, it gets converted into the metabolite called minoxidil sulfate, which opens potassium channels and therefore hyperpolarizes the cells in our vessels, leading to vasodilation. They only affect the arterioles, they don't affect the veins. So vasodilating our arterioles reduces the total peripheral resistance and therefore reduces our blood pressure. So that's how they work as antihypertensive meds. Okay. Indications. Okay, as I said, they are indicated for hypertension, especially for severe hypertension. They are very efficacious for severe hypertension. Interestingly, they're also used for the treatment of baldness if applied topically, because they can cause hypertrichosis, which just means the excess growth of hair. Adverse effects include, again, reflex tachycardia and increase in renin as compensatory mechanisms to combat the reduce in blood pressure induced by the drug minoxidil. We also get hypertrichosis, which is what I said before, excessive hair growth, and we get edema. So moving on to the other potassium channel opener, we have Diazoxide. So Diazoxide, the way it works, it just promotes the potassium channel opening, leading to hyperpolarization and therefore vasodilation, decreasing the total peripheral resistance and therefore decreasing our blood pressure. They are indicated for hypertensive emergencies, and I believe they are given via IV bolus or infusion. It's also used for the treatment of hypoglycemia caused by insulin-producing tumors, because diazoxide has the ability to reduce the release of insulin and therefore promote hyperglycemia. And therefore, we can get hyperglycemia as an adverse effect, especially at high doses.